Hello, this is Dr. Patrick Hwu, CEO of Moffitt Cancer Center and SITC president. We're so happy today to have Dr. Olya Finn. She has been really a foundational pillar in tumor immunology in the country and in the world. She has pioneered cancer vaccines, has really emphasized that we need to treat patients earlier in their disease process, has really helped to mentor so many people that are in the field today. So thank you, Dr. Finn, for being with us today.
Thank you very much, Patrick, for that wonderful introduction. Nice words, nice words. And of course, it's Olya for you always.
Great, thank you, Olya. Tell us how you got started. You came to America at a very young age from Yugoslavia.
Yes. This is something, my life story is a very good story to tell young people who are worried that they're not on a straight and narrow plan, and something happens, especially young women who are worried that they may have to, slow down at some point with family, etc. I tell them, no, life works out, right? You start in one way and you end who knows where, and it's always fun. I was born and raised in former Yugoslavia. And whenever I say to people, I came to this country at the age of 18, they say, did you escape? I did not have to escape. I was actually very much, into the socialism and, one for all for one, etc. However, at the age of 16, I met an American capitalist, a young student from the US. We fell in love, and after 2 years of writing and suffering the distance, we decided that the only way out is to get married and stay together for life. So we just celebrated our 54th wedding anniversary. So it wasn't planned, but it certainly worked out. But based back to how I started in science, science was also not going to be my life. My life was going to be theater directing, acting. People who know me better are not surprised when I say that. but in Yugoslavian high schools, at the time I went to this gymnasium, everybody did the same program of study in the first year. But from the second year on, you had to choose maths and science or art and languages. And because my father knew that I wanted to have a life in theater, etc., he made me a deal that he would support me in that dream. But I had to do math and science in high school, because as he said, it's going to be the last time in your life that you'll focus on science. So you might as well learn as much as you can. And it was fantastic for me, because when my life plans changed and I ended up, finishing high school in Yugoslavia, starting college here, in a foreign language, foreign, environment, science was comforting. Science was something that was solid, universal, international. Even if you didn't know English that well, it was still science language. And I just went right into it and, fell in love at that time with science.
Well, we're thankful to your father then for getting you to take science, and you contributed so much to the field. What brought you to Stanford in their immunology program?
Well, that's also a little bit of a roundabout way. When we got married, my husband had just finished Brown University and had a master's degree program set up at Stanford in communications, information systems, mass communications. So we headed from Yugoslavia to Stanford. He started his program there, and I entered Foothill Junior College, which is as a foreign student, because again, I had been in the country 2 months, so I entered, which is very near Stanford. The problem was that it was 1968. It was a very bad year. Vietnam was escalating. When we were planning our wedding, Martin Luther King was killed. Bobby Kennedy was killed. It was a horrible time. And when we arrived, as a married couple to the United States, my husband was actually drafted. So we continued. We went to Stanford, and he tried to do some, to figure out a way to serve his country, but not in Vietnam. So he joined the Coast Guard, and he was very lucky. Coast Guard officers candidate school. He was very lucky. He was one of only 200 people in 1968 to be taken in, of many, you had to be a college graduate, etc. So anyway, by the end of the fall semester at Stanford and at Foothill Junior College, he was already, accepted into the Coast Guard. We got in the car, drove back across the country. He went into the officers candidate school for 6 months. I went to live with my in-laws in Indianapolis, and I transferred all the credits from Foothill Junior College to Indiana University downtown campus. So, and that's where I finished my first year. And then he got his commission and was sent to San Juan, Puerto Rico. So our first wedding anniversary was in San Juan, Puerto Rico. I was, finished with my first year of college. I transferred all my Foothill College and Indiana University credits to Inter-American University of Puerto Rico. And it was advertised as a bilingual. You could be, you don't have to speak Spanish. It wasn't so. We had books in English, but you had to quickly learn Spanish. So I quickly learned Spanish. And anyway, graduated from Inter-American University in Puerto Rico. And just in time for Seth to be discharged from the Coast Guard. And then we sort of restarted our life. We went to Stanford, back to Stanford for him to finish his master's program. I was a biology major, right, at Inter-American, and I got a job as a technician, as a laboratory technician in the radiology department at Stanford with a very, very well-known cancer radiologist, Dr. Henry Kaplan, who in fact is responsible for the cure of Hodgkin's disease. He was the one who worked on that. He ran a lab trying to discover human leukemia viruses. He was neck and neck with a number of people, including Gallo, working on that. But I worked in his lab for basically a school year, sort of, and at that time applied to Stanford for a graduate program. And with his support and some other people with whom I worked, I got in. So this is, but there was no immunology training program, but there was the medical microbiology. So my degree is in medical microbiology with a focus on immunology. And Stanford was wonderful. You can imagine, Hugh McDevitt and Len Herzenberg. When I was just beginning to study immunology, Len Herzenberg was, figuring out the fax machines, flow sorting. We would go to his lab and there's all prototype machines, to sort cells. In McDevitt's lab, there were a number of wonderful people, postdocs who are all famous now. And, we were talking about spleen seeking and lymph node seeking lymphocytes, not T and B cells, right? So that was exciting early days of immunology. And I just, fell heads over heels. And I stayed at Stanford because when my husband finished his master's degree, he was offered to continue into his PhD. And I stayed as a postdoc with Ron Levy. So that was, again, another real injection of excitement and love for cancer immunology now. So that's, that was the beginning that I sort of never left behind.
Well, that's fun. What a great story, and to show that it works out. The path works out, and coincidentally, we just had a conversation with Ron Levy recently. So that's a lot of fun. So tell me though, when in those days when they could barely knew the characteristics of lymphocytes, absolutely no one was thinking that the immune system could be used to fight cancer.
Oh, absolutely.
You come to that conclusion, and what made you, work on this uphill battle of saying, hey, the immune response may be able to recognize and kill cancer cells?
Right. Well, primarily, as I said, my mentors, right? So, with Henry Kaplan, he was determined to find the virus, but part of it was because if it's a viral cancer, you might have a chance in terms of the immune system getting involved, right? So that was never far from his mind. And then also, definitely in Ron's lab, Ron was working on idiotypes, right? B-cell idiotypes as antigens on B-cell lymphoma. And he, of course, had this idea that this would be a foreign molecule for, for the immune system, a single idiotype expanded. So antibody idiotype. So, that would be a target. And of course, if, as you know, he had antibodies developed against those anti-idiotypic antibodies, but also vaccines based on the idiotype. Now, it was for the B-cell lymphoma, but again, it was the idea that, yes, you can do something. But just to your point, immunology, it was so exciting at Stanford. And even though, people are working on some basic things like Irv Weissman, and Hugh McDavid, as I said, Len Herzenberg, nobody really questioned. It wasn't focused on cancer, but nobody necessarily questioned whether immunology was important. Immunity was important in cancer. And it was not until I actually got my independent position. So nobody discouraged me to study cancer immunity, right? But when I got my independent position at Duke, there were a number of people who were so happy that I went there, but wanted me to change direction. And, department chairs and well-meaning colleagues, right, telling me that if I set up my lab to do cancer immunology, it would be a career suicide. And I was worried myself that, because I needed to get started strongly, right? And so I started my lab in transplantation and worked on cancer immunology in secret, actually, right? So we started by, just as I started my lab, which is 1982, IL-2 was discovered. We were growing jerk-cat cells and isolating supernatants to harvest IL-2. So we learned how to grow human T cells, right? I mean, you are a lot younger, but you were part of that tradition. So we grew T cells from biopsies from kidneys undergoing rejection and tried to understand. We knew the antigens basically, but tried to understand the repertoire. Are those very few T cells, or there are many different T cells, in there. So we learned how to grow T cells. And at that point, I said, good, we are officially a transplant immunology lab, but on the side, let's see if we can grow some tumor-specific T cells. And this is how, and I just put one student on it rather than 6 on the transplantation program. Because I got grants in transplantation, I was on a program project in transplantation, and all these tumor things were going on in secret until we grew them. We could show they're tumor specific. We isolated the antigen, et cetera. Then we sort of became public, and that's how and at that point I just went 100% into tumor immunology, and it was a funny sort of situation because at that point I was recruited to Pittsburgh, #1 transplant center in the world. And it's the day that I arrived here that I stopped doing transplantation, So this, nothing is a straight line, a zigzag, 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 but, you have a compass and you know where you want to go when you get there.
That's exciting. And a really great example because then really, it wasn't clear that the immune system could fight cancer. And many even top immunologists said, I don't know if there's any tumor antigens. I remember being in lectures, and they go, I don't know that the immune system can selectively kill cancer or not.
It's all part of self, right?
It's all chemotherapy. How do we up the dose of chemotherapy? And actually the bone marrow transplant was just to up the dose of chemotherapy, where it really ended up being the immune system that was allowing in the allo transplants. So this question about what's the antigen, are there antigens? I mean, that was a big question. And I remember really one of your early lectures, it's where I learned about MUC1 and how the sugar molecules on MUC1 was different in cancer cells compared to normal cells, even though the protein was similar. Tell us about the antigens that you're most passionate about. I know MUC1 you've been working on for a long time, and cyclin B1. Tell me about how you discovered those and how why you're utilizing the antigens you're using.
Right. So, I sort of, by learning as much as we could possibly learn about MUC1, and I think at this point, we know 90%, but there's still 10% that we, probably that we don't know. And then cyclin B1, it really led me to a completely different category of antigens. And in my mind, a completely different idea of what immunosurveillance of cancer is all about. And I'm still doing modeling and human studies, et cetera, to sort of support that idea. I think it's still fairly new to my colleagues, but I'm very passionate about this because I think it's going to help us a lot move forward quickly in terms of what we target or what we use as antigens for cancer vaccines. So initially, both MUC1 and cyclin B1 to me were, non-mutated tumor-associated antigens, right? MUC1 is a non-mutated protein. However, the protein itself is never seen by the immune system until it's made by the cancer cell, in which case it is differentially glycosylated, whole chunks of that protein that become, differential glycosylation is basically underglycosylation. So whole chunks of the protein that get uncovered and can be processed and presented to the immune system. So the normal MUC1 is like, that's heavily glycosylated, has a very large region of tandem repeats that are very heavily glycosylated. And if you give that form that's made by normal cells to a dendritic cell, for example, the dendritic cell will take it up because this is like sugars, right? So they have receptors for sugars, but they keep it close, proximal to the membrane. It never gets transferred to the antigen processing compartment. And then as soon as they can, they spit it out. So there's no, it's like I always say, it's chewing gum for dendritic cells. So no processing or presentation. And there is no processing, there's no presentation of T cells, there's no activation of T cells. The other thing that happens with MUC1 is that normal epithelial cells will make very little of it. That's one thing, but they will also make it show it only on the apical surface facing into the duct, and then they would also shed it into the duct. It's cleaved or shed into the duct, and it's part of ductal secretion. So it's really outside your body. It's inside the duct, but it's outside your body. The basolateral surfaces of epithelial cells that are surveyed by the immune system never show the molecule. And that all changes when the cancer. So it is, always present, but never presented unless there's cancer. And with MUC1, with the cyclin B1, it's a similar story. This happens in all tumor cells that have some p53, either deletion or mutation that eliminates the p53 function. Cyclin B1 goes sky high, and it gets and it's in the cytoplasm. It's not in the nucleus. It's dissociated from cell replication, and because it's so high, all of a sudden you have a lot of presentation on the cell surface of the cyclin B1 protein or peptides that otherwise you don't have. And it's interesting because you can give a cyclin B1 specific T cell, a tumor cell, or a T cell that's, you have activated, it's replicating. They don't see cyclin B1 on a replicating normal cell. They only see it on T cell. And it's a matter of the amount, actually, no mutation. What these two antigens taught me over the years is, and it was a very eye-opening, discovery, is that I just assumed that because we're looking at normal cells and we're looking at tumor cells, I just assumed that it's a transformation issue, right? You transform a cell, this is what happens. But actually, it is all due to inflammatory, signal. So whatever source of inflammation, acute inflammation, be it viral infection or bacterial infection, or something like inflammatory bowel disease, taking over, these two molecules, and then we found many others, change their expression. They become to look like the tumor molecules, right? So I began to think that if that change happens, early in life or multiple times during a lifetime, that every time, certainly for the first time the immune system saw it, it must have taken, gotten the signal to that this is something different. But then every time it happened again and again with another acute inflammation, acute infection, it's like a booster, right? So you end up over a lifetime with a very good memory for very specific changes that happen during these inflammatory but non-malignant conditions. So the tumor will just look like one of those conditions. So if you have a really good memory for that you've built over a lifetime, if a tumor starts to grow, and actually these antigens are expressed from pre-malignant states on, if the tumor starts to grow, your memory response should kick in. So I call these your first responders. And if your first responders come quickly, then you will begin to get rid of these lesions before chronic inflammation sets in and actually promotes their growth to cancer. So these are sort of disease-associated antigens that also work on tumors as tumor-associated antigens. And we have done a lot of mouse modeling to show that, for example, mice infected with flu multiple times, et cetera, when you park them in the animal facility for, until they get older, and then you challenge them with tumors, they reject the tumors. And when you look to see what are the targets, it's all of these antigens that are overexpressed during other conditions and changed in expression. We have also looked at cohorts of sera from people who, develop or don't develop cancer, et cetera. And we have found, long-term memory to MUC1 and, consequently, a much reduced risk for developing cancer over a lifetime. So these are, and the reason I'm excited about these is that we should be looking at those as targets or as antigens for vaccines, because if you really have a little bit of a memory response, it'll be easier at the older age to boost you, right, than to start completely new response to something, completely new. So in my mind, those antigens, if we make a whole list of them, they probably a much better candidate than a new mutation, a mutated neoantigen that is expressed in a single tumor, a single patient. We can do a much broader application of these antigens. And the other thing that we know is if you have a memory response and it's actually protective, they are safe. They out of the gate, you have a safe vaccine. So this is, and both MUC1 and cyclin B1 are those kinds of antigens. They were sort of prototype for me to start searching for new ones. And we found really quite a few. And interestingly, these antigens are very high. They are sort of what we used to call housekeeping genes. What are housekeeping genes? Those are things that are always present, very highly conserved. We didn't have any trouble, for example, with animal models because they're conserved across species, these molecules. So I think they are probably very important evolutionarily. And part of the importance is that they maintain the memory for disease, or as polymedicine would say, for the danger. I mean, they really are different type of danger signals. They're antigen-specific danger signals that the memory response, is generated to.
Well, it's exciting. So it really is a distinguished kind of vaccine. So when you're vaccinating against, for example, MUC1, you're not really doing priming
Right.
de novo from naive T cells, which is an uphill battle to try to prime a novel response. You think there's memory cells from past infections, flu, upper respiratory infections, other things that have already done the hard part, the priming, and you're just boosting. So it's almost a booster against the cancer when you use MUC1 based on the priming that occurred from viral infections.
Correct. And I think that probably in the majority of people, the cancer itself, the first pre-malignant lesion is a booster, right? Because not everybody gets cancer. So I think that the cancer itself is a booster, but so with people at very high risk for developing cancer, it would be good if we can reproducibly boost so that we know that these people are prepared to face, the change when it happens. And when, cancer starts to grow in an older individual, it's very hard to, we don't have that many. I don't have so many naive cells. I mean, they've all seen something, right? So going for something that they have seen that's also expressed on the cancer is, I think, going to be very important.
You've also been a champion of treating earlier stages of cancer. and not waiting to the late stage. Because a lot of cancer drugs, the paradigm is let's do it in the end stage patient, late advanced cancer, and then move it earlier. You've always said you got to start much earlier for cancer vaccines. Can you talk about that?
Well, to me, just, to this day, I see people say, we have to show first that it works in an advanced stage, and then we can move it up. But I think you completely undermine the effectiveness by testing it. I think we have lost a lot of very promising things by not being able to show that they work in an advanced stage, and then we have no chance of moving it to an earlier disease. I think the other problem is that it's also the level of success we expect in the end stage. I think we've seen successes, right? But they've never been high enough for somebody to invest millions of dollars to develop the treatment. And I think that as we move to an earlier stage, and pre-malignant stage is really my target now, we may get levels of success that will encourage somebody to actually develop the vaccine and somebody is usually big pharma, because without them, it remains an academic exercise. So and I can just give you an example. We have tried the MUC1 vaccine, exactly the same identical MUC1 vaccine in colon cancer patients, and we do get 2 to 3%. I mean, it's hard to know really if it's due to the vaccine or not, but we do get about some patients to respond to the vaccine. And we're looking at, for example, IgG, because anti-MUC1 IgG, it's a surface molecule. I like antibodies. I think they're effective against surface antigens. So we measure IgG, and also indirectly, then you measure T cell activity, right? But we knew that in a few patients we will get it. So we know that the vaccine is active, just not in everybody, but it's 2 to 3%. And also levels are very low, statistically significant, but you don't know if they're biologically significant. Then we use the same vaccine in polyp patients, right? Those at high risk for developing colon cancer. So these were patients, people who developed polyps. The polyps were removed, and these were adenomatous advanced polyps. We vaccinated them, hoping that they would just then not develop new polyps. 47%, in our feasibility study, 47% of people responded to the vaccine. The other 53% we saw were immunosuppressed the same way as cancer patients, which was very interesting because this is a very advanced pre-malignant state. And these 47% that responded, Patrick, they had 40-fold over baseline, whereas we got 2-fold over baseline in cancer patients, and that was in our clinical trial, that was the requirement. The responder was a person who went 2-fold over baseline. We had 40-fold, 30-fold, 20. It was like, it was a dream. And the same vaccine. So you have to decide it's not the vaccine, or it's not whatever therapy you're using, it's the patient. And if we can choose the right patient, I think our treatments would be much more promising and much more attractive to pharma to develop.
That's exciting. So certainly treating earlier patients may have stronger immune systems in those patients. The patients that already are suppressed, though, is there anything we can add to the vaccines to get them to respond and have the 40-fold increase?
Exactly. I mean, that's where our focus is now, right? So and we are only testing one vaccine, and my dream is that everybody will test their own vaccines in the pre-malignant setting, because their vaccines may be better than mine. So maybe more patients will respond. But what we found was that the major issue with those that don't respond is the myeloid-derived suppressor cells. Another sort of scientific enigma that for a while people didn't really want to hear about, but they're very important. And so if we can manipulate them prior to vaccinating or in the process of vaccination, I think we're going to have a lot more success. And this is where we're focusing now. And a number of my colleagues are working on it, like Augusto Ochoa is working on some systems, in fact, repurposing drugs that were for some other things that are known to be safe. And I think that's the promising arena. The other thing is that is moving even earlier, right? I mean, because if we pre-tested our patients for MDSCs, we could have 100% responder rate. right? So that's precision medicine, in my opinion, right? You can work on improving your treatment, but you also, is giving it to the right patient is also going to be a good approach, right? If we don't have anything, then use something else for the other patients. But this is where, and the reason I think that we could be very successful if we deal with some of these suppressive mechanisms is that we compared T cells from, stage 4 colon cancer patients and pre-malignant lesion, adenoma patients, so polyp patients, and for the suppressed ones, and they're both equally suppressed. But if you take the MDSCs out, the polyp-derived T cells, polyp patients' T cells, are perfectly functional. The stage 4 are not functional anymore. So there's an irreversible suppression in the end stage cancer. So even if you remove the MDSCs, things are not going to do very well. But here they're perfectly good. So that's another. They haven't had enough time to be fully immunosuppressed, etc. So, and as you know, that's a whole new area of investigation. In when do T cells change irreversibly? But we know that in the adenoma patients, they have not changed irreversibly, just by their function. We haven't done any epigenetic analysis or anything like that, just by their function.
Do you ever see a day when we take patients with germline predispositions for cancer and just immunize them?
Yes, I imagine it. I will never see it, unfortunately, but I imagine it. Because I think it's absolutely, I think it can be done today.
Yeah. Well, why don't we just do it today?
But
why don't we do it today? If someone with a BRCA mutation predisposed to cancer, yes. Why can't we just do it
why
today?
Can't we do it? I know. And because because we can do it in an investigator-initiated clinical trial of 12 patients, right? We cannot do it without the phase 3 trials, and we're not doing it. But if I were really rich, that's where I would put all my money before I went, but because just a case in point, for example, I have been talking about the very first clinical trial ever that we started, and it was first in the world with non-mutated, self molecule. Was in 1993. Mike Lotz was the PI of the clinical trial. I was his scientific co-PI. We did MUC1 vaccines in 63 patients here, but all stage 4, breast, colon, and pancreas, all stage 4. I would go meet these patients, and they were in such bad shape that my knees would be knocking as I was walking back to the lab. I didn't have any resistance to, seeing patients suffer like that. And when we started put the first patient on the trial, we were interviewed by newspapers and television, and we were on the front page of Pittsburgh Post-Gazette. But we said, we are starting this so that someday we can inject this vaccine in people at high risk for developing cancer. And this was 1993. It's going to be 23. In 30 years, and we haven't yet done it. I've done it, and I sort of come full circle, and I'm really happy about that. I personally have done it, but it isn't a general, thing that's happening. And at that time, and I was already advocating for that. And I remember talking about MUC1 as a breast cancer vaccine for women. Why would we have double mastectomies for women with BRCA 1 and 2? Why can't we vaccinate them and just survey, and somebody in the audience, I probably was an ACR meeting, stood up and said, so what are you suggesting, that we vaccinate, 25,000 women and we wait for 20 years to see if the vaccine is working, right? That's what people were conceiving of a preventative vaccine. And I said, no, that's not, you start with a smaller number at a particularly high risk, and I explained that. But even if that's what we had done at that time, we would have already had the answer. 20 years have gone by and we don't have the answer because it just isn't. And I'm always surprised that I have to say, as dependent as we are on big pharma, I'm also very disappointed in big pharma, because I think that their sights are too nearsighted. They're too short term. If something doesn't work in 3 years, they give it up. I think that if you're in the situation where running big pharma, you have to pick up things today that might give you something 25 years from now. I mean, you just have to have this long view. Otherwise, everything is, I think otherwise we waste a lot of great science and great potential to cure people because we give up too fast.
Yeah, well, I think we can get this done now. If the cohort's even bigger, then you can do it in a shorter period of time. So
absolutely,
I hope that we can do this soon. If not, one of your mentees will do it because you've been an amazing mentor to so many people. And I also want to point out your engagement with SITC's Women in Immunotherapy Network and what you're doing with the WIN and mentoring everybody, and especially women scientists. Can you talk a little bit about that?
I think it's really very important. As you said, I've had equal numbers of men and women and as trainees in my lab, right? But as a my outside activity, I'm very dedicated to mentoring women scientists because and I think part of it is because I want to make sure I see these women and they're incredibly talented and they're incredibly smart. And I see that all they need is a little bit of support, right? But they are, because that support is not there, societal support is not there, often family support is not there because they may be the first time, somebody from the family went to college. And I've had all this, happen to people in my lab, who were discouraged from success. And so the women who have the ambition and have the knowledge and the talent often don't realize that what's standing in their way is the society and and no support. Often they think it's them, that they're not progressing fast enough, so maybe they're not good enough. And my important message I always want to give them, it's not you. you have done everything and you just have to continue to do everything. And then also to encourage them to go for it in spite of this, but also to fight for additional support. And I have to say that, so this was the 4th WIN Institute in Seattle that we attended and we, taught at. And I'm so gratified to see the generation coming after us. I mean, our science is very lucky to have all these women in it. But at the same time, I personally feel like a failure because we are talking about the same issues that I fought for in the 80s, in the 90s, in the 2000s. We're still talking about the same thing, and we're still sort of leaving it to them to fight the battle. I can't believe that we haven't yet won that battle. I mean, there's still almost no daycare centers at universities, that can satisfy the demand, right? There's one here and there. I know we have very little of that opportunity in the University of Pittsburgh to accommodate families. And it's becoming, one thing that's gratifying to me, that it's becoming less of a women's issue, even though it's primarily a women's issue. But there's some young faculty, male faculty, that are now getting the same message because, if they want to be good parents and sharing co-parenting, et cetera, they need the same resources and they're realizing that they're not there. So as I said, it's these interactions with my younger colleagues are incredibly gratifying, and at the same time, very sort of I'm just not happy with myself that I'm leaving the same battles to them. And that really bothers me.
Well, you can be happy to know that now people aren't questioning whether the immune system can help.
Okay.
So
one success at a time. Yeah. One success at a time.
Yeah. Well, next time you visit us at Moffitt Cancer Center, we're going to go visit our very robust daycare center. So I would love for you to see that. It's
absolutely.
a wonderful program that we have here. But thank you for leaning in with SITC and on the Women in Immunotherapy Network. You're recently at our retreat to try to plan the future future of SITC. You've received the highest awards from SITC. Tell us about
that I'm grateful for.
with SITC and what SITC means to you.
You know, somebody told me, so you've been a member of SITC for 5 years. And I said, oh, much longer than that. And the reason that, you know, it's officially 5 years is because SITC, as you know, has been other societies before, right? It sort of was born from other societies. So in 1989, 90 or so, I was a member of the Society of Biological Therapy of Cancer, SBTC, right? So to me, it was sort of, it's a continuum. So as far as I'm concerned, it's been 20 some years, not 5 years. But the reason that, and I was very active in it, mostly for the same reasons that people are active in SITC now, and that is it's focused on cancer therapy, it's focused on cancer immunology. And at the time, in the late 80s, that was not AAI and that was not AACR, you know? So, you know, if you're an AAI member, AACR member, a cancer immunology session may have been the last day, the last session that nobody attended, right? And AACR used to say, no, nobody will come. You know, we don't want to have a session on cancer immunology. Nobody will show up. So it was frustrating to cancer immunologists, very frustrating. So what I did, so and SBTC was a small society. It didn't have the impact that it needed to have to get these large societies to sit up. Now they look at SITC and they go, you know, look at all the members that SITC has. So my decision was really that if we stayed just in SBTC, right, 60 some people or whatever, and talk to each other, we're not gonna make a big impact, right? So it's better to really work within AAI and AACR and bring cancer immunology up. So I did everything on both societies. And you know, I don't join a professional society to just be a member. I joined to do something. So, you know, so I fought very hard at AACR to get and I had lots of, you know, I had Lou Wiener, for example, was my co-warrior in that effort. And then if you can look now, the Cancer Immunology Working Group at AACR is a very active working group, lots of wonderful people that are also members of SITC. And so we are moving that, you know, in both societies, promoting cancer immunotherapy and cancer immunology. At AAI, I was elected to council for 7 years, and I was president. And at that time, so with my presidency, with Jim Allison's presidency and Louis Lanier presidency, those are cancer people. We really brought up cancer immunology to the forefront of the AAI, you know, programming and support, et cetera. So I worked very hard. So I started with SBTC. I worked very hard at AACR and AAI to get cancer immunology to, you know, to be noticed. As I said, with great teams. We also fought a lot of battles, you know, at NCI to get cancer immunology funded and networks funded. So that was with, you know, Mac Cheever, with Ralph Steinman, also Lou Wiener, myself, Liz Jaffe. So there was a lot of activity going on, and you know, then I joined SITC when you know it rejoined SITC, right, 5 years ago. But because I had done what I needed to do at AACR, I had done what I needed to AAI, and now I just go to the meeting and I relax because everything's happening the way I really wanted it to, and I thought that I could now put my efforts and give whatever is needed to SITC, because I have the time, I have the knowledge, I have the desire. And so that's, you know, that's where I am now with SITC. So you can ask me anything, to do anything, I'll say yes.
That's wonderful. And we appreciate all of your history with the ISBTC and everything you've done through AACR for cancer immunology. You did start that wonderful cancer immunology working group with AACR, right, of which I was actually led for a couple of years.
I know, exactly.
And so it's started it. Yeah. So so it's really a major part of the AACR now too. So
we had one of the things you would have seen on my wall. Now it's all packed away. Is a big poster for the very first AACR special conference in cancer immunology that I organized in Lou Wiener. Yeah. So
Yeah, that's wonderful. Hey, I was really interested to hear about your original thoughts about theater. So tell me a little bit, are you involved in theater now, or what kind of theater? Are you doing any
I'm not,
acting or going
yeah,
to plays? They have a good, vibrant theater
right.
program in Pittsburgh. I know Carnegie
Yes.
Mellon's big in theater.
Right, right. I am now only in the audience, right? But I would say, Patrick, that every time we give a talk, I give a talk. It's a performance, so it helps me to have that affinity. I am a very good teacher because my lectures are performances. So it's I'm not. I mean, since I wanted to be on stage, I am I'm comfortable giving lectures and giving talks. And I'm a director, every time in every lab meeting, right? They have to give a perfect presentation. They have to speak loudly and, things like that. So, so I train my trainees to perform. But we have a wonderful Pittsburgh Public Theater here. And because of my schedule, we buy these flex passes where, we buy the whole season, but you call in, for dates, etc. So that's been wonderful. It's a really wonderful theater. Pittsburgh it's a great place to live and work because it's an easy life. You don't have to spend all your time, getting to work or getting back from work. You can actually in 10 minutes you're downtown after work and you're in the theater and you're in the symphony. We have a fantastic symphony. So one thing that I really liked about Pittsburgh is that you can really work hard, but also be surrounded by these cultural events that you have access to and you have time to go to.
Wonderful. Well, you are a great speaker. So now I know why. It's a theatrical background. You're also a very proud parent and grandparent now.
Absolutely.
Tell me a little bit about your family.
Yes. So I have a son and a daughter. And in fact, my son is 48, and I was talking to my husband and said, is it possible that we have a child who's 48? I can see the grandchildren fine, but when I see the number, right, how old are we? But he's a dermatopathologist, and I have a little framed write-up by him when he was in first grade. No, he was probably second or third grade. I was already at Duke, and he wrote, when I grow up, I want to be an immunologist. And he wrote this beautiful piece about, immunology is such an interesting science there. But most of all, my mom is having such a good time being an immunologist, so much fun being an immunologist. So then he went to Brown, he went to, graduate. Then he went to the MD PhD program at Duke, MSTP program at Duke, and it was very interesting because he was accepted to many MSTP programs. He chose Duke because of the basketball, right? Coach K. So anyway, he's a hard worker, but he has his priorities, right? Anyway, he's a pathologist by training and fellow in dermatopathology from Yale, and he is a dermatopathologist in British Columbia, Victoria, British Columbia. They recruited him up there, and he's very happy there. And so he has two children. My granddaughter Sophie is 19, and she is studying her junior year at Stanford. And she's planning to graduate this year at the end of her junior year. Due to pandemic, the first year she was at home as a freshman, she had taken so many classes, she's ready to graduate. And this week, she's taking her LSAT, so it's her law school entrance exam. And her brother Luca is 14, beautiful, brilliant. He was a couple of years ago on 7 different sports teams, but he's also a straight A student. And then I have a daughter, Sonia, was 5 years younger, and she went to Columbia, but after that, she went to the Culinary Institute of America to become a chef.
Oh, near Poughkeepsie?
In Hyde Park. Yeah, exactly. Hyde Park, New York. It's near Poughkeepsie.
Yeah, that's my daughter went to Vassar, so
that's where it is. Yeah. And so she got her chef's degree, went to California, was with Judy Rogers, and part-time with Alice Waters, etc. Trained beautifully, and then came to Pittsburgh and opened a very highly acclaimed little restaurant, Dinette, which she, after 12 years of running a successful restaurant, a very popular restaurant, she had to close it due to the pandemic. But she pivoted really quickly. She applied to many MBA programs around the country and got into the Carnegie Mellon Tepper School of Business. She finished her first year. She's in Seattle doing her internship at Ernst & Young, coming back to finish her second year, and then she's off. She ran a successful business. Now she's learning the theory behind it, right? And she has a 10-year-old, Miles. So that's the family. And, they make us very happy. And we managed to see each other quite a bit. The pandemic was difficult because we are so used to being together at least 4 times a year for at least 2 weeks at a time, et cetera. But the pandemic kind of got in the way, but we recovered this year. We've had as many reunions as we could get.
It's wonderful. And you're also one of my role models for how you can be very successful professionally and also have a wonderful private life. You have a place in Italy that you go to.
Oh, I do. And in Florida. And in Florida.
You have a place in Florida? I didn't realize that. All right. Well,
across from Tampa. Yeah, on the East Coast. It's one life, right? You just gotta do it all. And you can have it all. Maybe not all at the same time. And maybe when you look at me, I'm 72. I had a lot of time to get here. So, if you want to have it all at 20, maybe not, maybe at 30, maybe not, but you want to live a life so that when you're 72, you have it all, right? Just prioritize things differently, but do them all.
All right, that's wonderful. It's been so lovely talking to Dr. Olya Finn from the University of Pittsburgh, someone who was a pioneer in tumor immunology, has contributed so much to our field and mentored so many people. So thanks so much for being with us today.
Always a pleasure being with you, Patrick. Thanks for having me.